Hi to everyone who's joining us for this session, which is MTC in MEN2 and MEN3, implications for the patient and their family. It was an honour for MEN to have been invited to do this session by ThyCa. So our huge thanks go to Gary Bloom and the ThyCa team. My name is Jo Gray, and I'm the CEO of the Association for Multiple Endocrine Neoplasia Disorders, or AMEND, here in the UK. AMEND supports families in the UK and beyond with multiple endocrine neoplasia syndromes, as well as medullary thyroid cancer and a handful of other rare endocrine diseases. We develop free patient information resources and provide free support services, as well as offering an annual research fund. I am also a patient with multiple endocrine neoplasia type 2A and a medullary thyroid cancer survivor. My MEN2A was diagnosed 22 years ago this year after a 4-year diagnostic odyssey. I'll put that politely. I was initially diagnosed with a Phaeochromocytoma, an adrenal tumour, and thereafter with MTC and finally MEN2A. And in 2007, I lost my left shoulder to an MTC metastasis, after which things now have been pretty stable, thankfully, for several years. So I'm delighted that both of our speakers for this session immediately said yes to being involved today, and I'm very grateful to them for joining us. Firstly, we're going to hear from Dr. Ruth Casey, who's a consultant endocrinologist at Cambridge University Hospital NHS Foundation Trust and a senior research associate in the Department of Medical Genetics at Cambridge University. Dr. Casey has a large clinic of hereditary endocrine disease patients, and she'll be giving us an overview of the MEN2 and MEN3 syndromes, touching on inheritance, tumour risk, screening protocols, and preparation for surgery. Then we will hear from Mr. Tom Kurzawinski, who is a consultant pancreatic and endocrine surgeon at the University College, Royal Free and Great Ormond Street Hospitals in London. At the Great Ormond Street Hospital for Children, he has developed a great deal of experience in thyroidectomy and prophylactic thyroidectomy in children with MEN2 and MEN3, and he'll be talking about surgical approaches to MTC in MEN syndromes, potential complications and postoperative follow-up, among other things. After the talks, we hope to have plenty of time to take questions via the Q&A facility, which is below on your screen. And we'll be doing that until our time is up. So thank you very much for joining us. And Dr. Casey, would you kindly like to start us off?
Yes, thanks, Jo. And good evening, everyone from the UK. So my name is Ruth Casey. As you've heard, I'm a consultant endocrinologist at Cambridge University Hospital, and I'm really delighted to be here this evening with you all. So my talk is going to focus on the tumour risks in patients with MEN2 and MEN3, and in particular going to focus on phaeochromocytoma. And we're going to talk a little bit about the surveillance and screening that we should consider for patients with MEN2 and MEN3. Okay, so let's start by first asking the question, what is MEN2 and MEN3? Well, these are genetic syndromes that are typically caused by an inherited fault in a gene called RET. Occasionally, these syndromes can arise because of a de novo or spontaneous fault in the RET gene in some individuals. And depending where in the DNA sequence of the RET gene that the fault occurs, and therefore where in the protein that the damage is, that will help dictate, or that does dictate, what tumour risks that patient will have. And it also helps to guide our surveillance, as we'll see later in the presentation. So depending on the exact RET mutation, then patients may develop either MEN2, where they're at risk of developing medullary thyroid carcinoma, phaeochromocytoma, or a condition called primary hyperparathyroidism, whereby there's overactivity of one or more of our 4 parathyroid glands, which can lead to elevations in calcium and subsequent complications that I'll discuss a little bit later. MEN3 then, again caused by a different specific group of mutations in the RET gene. MEN3 is associated with a very high risk of medullary thyroid carcinoma. These patients can also develop phaeochromocytoma. These patients do not develop primary hyperparathyroidism to the best of our knowledge, but they can develop other developmental anomalies, again, which I'll mention a little bit later. The final category is a category called familial medullary thyroid carcinoma, and patients with these specific RET mutations are only at risk of MTC or medullary thyroid cancer and not the other tumours. I should also mention, just for clarification, that when I now talk about MEN2, I'm referring to what used to be called MEN2A, and when I talk about MEN3, I'm talking about what used to be referred to as MEN2B. Okay, so if we take a closer look at the tumours then. So for patients with both MEN2 and MEN3, the highest risk or the most penetrant tumour type is medullary thyroid carcinoma. And if we look at patients with MEN3, for example, they will have 100% lifetime risk of developing medullary thyroid carcinoma, often very early in life. A medullary thyroid carcinoma develops from overactivity of a specific cell type in the thyroid called the C cells. And when this type of cell in the thyroid becomes overactive, it can lead to secretion of a peptide called calcitonin. And that's why we measure calcitonin as a screening test in patients with suspected or confirmed MEN2 and MEN3 in our clinics. What about phaeochromocytoma? Well, this is a rare neuroendocrine tumour that arises from the adrenal gland, which is a hormone-rich gland that sits on top of our kidney, one on the right and one on the left. Phaeochromocytomas can therefore secrete hormone, and specifically they secrete catecholamines or adrenaline, which means that patients who develop these tumours can present with symptoms such as headaches, flushing, sweating, palpitations. They may have high blood pressure, or they may have irregular heartbeats. The risk of developing a phaeochromocytoma will also vary depending on the exact RET gene mutation, but for patients with MEN3, for example, the risk is about 50%, and for patients with MEN2, the risk can vary between 10 and 50%, again, depending on the RET gene mutation. What about primary hyperparathyroidism? So this is a condition, like I said, where there's overactivity of one or more of the 4 parathyroid glands that lie in our neck, either side of the thyroid. If the parathyroid hormone is in excess, that stimulates excess calcium release from our bone. And then that excess calcium release in our bloodstream can cause damage to our kidneys by accumulating in the kidneys, or can cause kidney stones. And because there's increased bone turnover, it can predispose to osteoporosis. The risk of primary hyperparathyroidism only exists for patients with MEN2 and is approximately 10 to 30%. Then there are other conditions that can also arise in patients with MEN2 and MEN3, including a skin condition, which is pictured here, called cutaneous amyloidosis, a condition called Hirschsprung's disease, which usually presents in infancy and is again caused by dysregulated nerves in the large intestine, which affect the motility of the bowel. Patients may develop tiny neuromas of their eyelids, mouth, or tongue, and they can also develop, again, nerve-type tumors called ganglioneuromatosis in various places throughout the GI tract. So if we take a little bit of a closer look between the correlation in the RET gene fault and the tumor risks, I think this helps for patients to understand and for clinicians to understand why we sometimes tailor the surveillance to individual patients depending on the RET fault that they have. So as years have gone on and as we've been able to study the correlation between specific RET faults or RET variants and the tumor risks that patients have, we've been able to start to categorize the RET variants into 3 main categories. And this classification was developed by the American Thyroid Association and recently updated. But there are 3 large classifications, so highest, high, and moderate. In the highest category includes patients with MEN3. These patients are at very high risk of developing medullary thyroid carcinoma at a very young age, so it's recommended that children of patients with these gene mutations are offered genetic screening in the first year of life, and ideally have a prophylactic thyroidectomy within the first year of life. The risk of phaeochromocytoma is about 50% in these patients in the highest category, and therefore it's recommended that screening for phaeochromocytoma starts between the age of 8 to 11. For patients in the next category, the high category, this includes some patients with MEN2, Included in this is one of the most common variants that we see in clinical practice, which is a mutation in the RET gene affecting the DNA sequencer codon 634. For this patients in this category, it's recommended that for children, they are offered genetic testing in between the ages of 4 to 5. And if they have the RET gene fault, they should be offered a prophylactic thyroidectomy, typically before the age of 5 or before they start school. The risk of phaeochromocytoma in this category is similar to the highest risk category at 50%, and therefore, again, screening for phaeochromocytoma is recommended to begin between the ages of 8 to 11. The risk of primary hypoparathyroidism in this category is about 20 to 30%, and screening for primary hypoparathyroidism can start around the same time as phaeochromocytoma screening, because it's typically a blood test. The final category, which is moderate, for this category, children should be offered genetic testing between the ages of 16 to 18 years. If they carry the gene fault, it's generally recommended that they're referred to a specialist clinic where they're offered 6 monthly to annual clinic reviews and testing for fasted calcitonin levels. And if the calcitonin levels are seen to become elevated, then those patients should have a thyroidectomy. The risk of phaeochromocytoma in this category is about 10 to 30%, and screening should begin around the age of 16 years for phaeochromocytoma in this category. So looking a little bit more closely at phaeochromocytomas then. So as I mentioned, the phaeochromocytomas develop from the adrenal glands, which sit over the kidney. It is also possible to develop a similar type of tumor outside of the adrenal gland, and in that situation, it's called a paraganglioma. I should mention that for patients with MEN2 and MEN3 and RET gene mutations in general, the risk of paraganglioma is very low, if not zero. So patients with RET gene mutations will predominantly develop adrenal phaeochromocytomas. They can be bilateral, so they may affect both adrenal glands, and that might be bilateral tumors at presentation, or a patient may develop a phaeochromocytoma, have it removed, and years later develop a subsequent phaeochromocytoma. Most commonly in patients with RET gene mutations that we know about, these tumors should be picked up very early through surveillance. But of course, there will be patients who present not knowing they have RET gene mutations. And in these patients, typically the tumors will present because the patients have symptoms related to the catecholamine excess, such as headaches, sweating, flushing, palpitations, like I mentioned. It's also important to note that phaeochromocytomas do have malignant potential, although again, malignant phaeochromocytomas are exceedingly rare in patients with RET gene mutations. These pictures here just give you an example of what the tumors can look like. So the bottom picture is a smaller phaeochromocytoma, and the top picture is a much larger phaeochromocytoma. We would hope that in patients with known RET gene mutations, we would not be picking up patients at this stage. It's usually much, much smaller because we'll be screening them more frequently, but they can get to this size in patients who are not aware that they have a genetic predisposition. So like I've mentioned, the risk of developing a phaeochromocytoma can vary depending on the RET gene mutation. The highest risk is for patients in the high category and the highest category. So some patients with MEN2, including those who have the common genetic mutation affecting the codon 634, and patients with MEN3. Usually phaeochromocytoma will be the tumor that develops later. Medullary thyroid carcinoma is much more common to develop early in patients' life, and phaeochromocytomas typically develop in the third or fourth, or present in the third or fourth decade. Tumors can be in both adrenals in about 30% of patients, and like I said, thankfully, malignant phaeochromocytomas are very, very rare in patients with MEN2 and MEN3. So how do we screen patients for phaeochromocytomas? Well, it's important to understand a little bit about how the hormone production occurs in the adrenal gland, because this helps people to understand why we rely very heavily on biochemical testing in patients with RET gene mutations. So the machinery that leads to the production of catecholamines or adrenaline in our adrenal gland involves a series of enzymes pictured here. One of these enzymes, PNMT, tends to be upregulated in patients who have RET gene mutations. And this particular enzyme is responsible for converting noradrenaline to adrenaline in the adrenal gland. So if you have a RET gene mutation, you will be making an excess of adrenaline. That is good news for us because it means that biochemical testing is a very, very sensitive way of screening patients for the development of a phaeochromocytoma. So therefore, it should not be a surprise that the first line and standard of care screening tests for phaeochromocytoma in patients with any genetic predisposition really to developing a phaeochromocytoma, but in particular patients with RET gene mutations, should be plasma or urine measurements. And we now know that the most sensitive and specific way of detecting these hormones is using a test called plasma-free metanephrines or urinary fractionated metanephrines. These tests are typically run on what's called a mass spectroscopy assay, and it is important to make sure that whatever hospital you're being reviewed in do have the most sensitive and specific assay to test for these hormones, because we want to be able to trust the results that we get. It should be mentioned that obviously to reduce anxiety for patients, we want to make sure the test, as well as being sensitive, is also very specific. For that reason, plasma-free metanephrines should typically be collected in the fasted state and should ideally be performed lying down, i.e. in the supine position, for at least 20 minutes before the blood is drawn. So I wanted to look at a quick case, which I think highlights a few points that we have discussed and will be discussing. So this is a lady that I met about 5 years ago now. She was referred to her service because she had a high blood pressure, and the GP was concerned she might have a secondary cause for her high blood pressure. She had recently moved from Slovenia. She was able to tell me that about 20 years prior to her moving to the UK, she'd had a thyroidectomy in Slovenia, but she wasn't entirely sure why she'd had that thyroidectomy. She was also able to tell me that her mum had a history of kidney stones and a history of thyroid cancer. She had no known genetic diagnosis at the time that I saw her in my clinic. She was indeed hypertensive. We did indeed work her up for a secondary cause, which would include measuring these hormones, plasma-free metanephrines. And what we found was that they were markedly elevated, as you can see here highlighted in yellow with the reference range to the right. Therefore, armed with this information that she had excess catecholamine production, we did a scan which showed that she had a right-sided adrenal mass, as you can see from this picture, consistent with a phaeochromocytoma. She went on to have another type of test, a nuclear medicine test called an MIBG SPECT-CT, which again was just to confirm the diagnosis of a phaeochromocytoma. This particular tracer gets taken up by an enzyme, or an enzyme called an norepinephrine transporter, which is typically overexpressed on phaeochromocytomas and therefore can help to confirm a diagnosis. So what we see on the scan is that the right-sided adrenal mass was very, very bright in this scan, again confirming this was likely to be a phaeochromocytoma. Thankfully, we didn't see any other areas of tracer high tracer activity anywhere else in the scan to suggest that this tumor was behaving in a malignant way. But what we did see was on the SPECT-CT part that didn't have any tracer was this lytic area in the patient's hip, as you can see here, marked by the white arrow. Because it didn't have any tracer activity, we were quite suspicious that this was not related to the phaeochromocytoma. And so we went back to the drawing board. So as I mentioned, we had very little information about this patient before she moved to the UK, but we knew her mother had a history of thyroid cancer and kidney stones, and this patient had a thyroidectomy and she wasn't fully sure why. But all of this was and should have been ringing alarm bells that this patient could have a diagnosis of MEN2 or MEN3, but more likely MEN2. And so we checked a calcitonin level, wondering whether that lesion in the bone or the hip could be related to the previous thyroidectomy, which may have been for medullary thyroid carcinoma. And indeed, the calcitonin level was markedly elevated in this patient. Genetic testing confirmed that she did indeed have a RET gene mutation, and a subsequent biopsy of the lesion in the hip confirmed metastatic medullary thyroid cancer. This lady was referred to oncology for subsequent treatment, and her 4 children were tested, 3 of whom tested positive for the RET gene mutation. So if we look at our patient for a second, so she had this mutation affecting codon 634, which I've mentioned is one of the more common gene mutations that we see in patients with MEN2. So for her children, it meant that any of the children who were between 4 to 5, in fact, they were all over the age of 5 when we picked them up, should have their thyroidectomy. And then we started to do screening for phaeochromocytomas when the children got to the age of 8. Okay, so what's your clinical surveillance look like then? Well, for most patients, by the time they get to my clinic, they've had a prophylactic thyroidectomy. As mentioned, that should be according to their RET gene mutation, according to the ATA risk category. So that will dictate what age the patient should have the thyroidectomy. And I know Tom will speak a little bit more about that later on. So usually I come to see the patients around the age of 8 when they should start their phaeochromocytoma screening. So they will typically get a blood pressure check and a clinical assessment for symptoms, including any symptoms of headaches, abdominal pain. For children, it's obviously also important to ask whether they're having any difficulties in school, particularly with attention or concentration, or any difficulties with exertion or exercise. Patients will also get biochemistry, so that should include, like I said, the plasma or urinary-free plasma-free metanephrines or urinary fractionated metanephrines. Patients should have a calcium level checked and a parathyroid hormone level checked, a vitamin D level checked. And of course, if they've had a thyroidectomy, we should be checking their thyroid function to make sure that their thyroxine replacement is adequate. And we also check renal function because of the risk potentially that calcium can have on the kidneys. If there is any clinical or biochemical suggestion of catecholamine excess, it's important to consider imaging in these patients very early. And that's because we want to pick up these phaeochromocytomas at a very early stage. So for some patients, because we're screening them so frequently, it may not be that the catecholamines even become outside of the range, but we start to see a gradual increase in the level. It may still be within the reference range for that particular hormone, but even seeing that steady climb should prompt us to think about imaging for that patient with genetic predisposition to developing phaeochromocytoma. So if we do diagnose a phaeochromocytoma, what considerations do we need to give to preparing the patient? Well, if a patient with MEN2 or MEN3 is being considered for surgery or any invasive procedure that requires a general anesthetic, or if they're planning a pregnancy, it is really important that the patient has up-to-date biochemical testing to make sure they don't have a phaeochromocytoma. For patients with a diagnosis of phaeochromocytoma, surgery for that tumor should be performed after an appropriate duration of medical therapy using an alpha blockade. So this could include medications such as doxazosin or phenoxybenzamine, and typically should be overseen by an experienced physician in an experienced center. And it's also highly advisable that patients with a diagnosis of phaeochromocytoma, as they're undergoing their preparation and awaiting surgery, are given an alert card so that other physicians, pharmacists or healthcare workers are aware of their diagnosis. This is particularly important as we want to avoid these patients being prescribed certain medications. And this is just an example of a card that Amend and Joe have kindly provided us with, which is used throughout the UK and allows patients to fill in the dose of alpha blockade that they're in, as you can see here, and contains a list of medications that patients should avoid, so that patients can carry this in their wallet or in their pocket. And any time that they're being prescribed or offered a medication, they can show it to make sure they're not offered one that may worsen their hormone production and precipitate a crisis or clinical symptoms. Briefly, I also just want to mention the surgical management or surgical approach for patients with RET gene mutations who develop a phaeochromocytoma. Like I mentioned, some patients will be at risk of developing bilateral phaeochromocytomas, so which means that over their lifetime, they are at risk of losing both of their adrenal glands. That's relevant because I mentioned at the beginning that the adrenals are hormone-rich glands. As well as making adrenaline, they also make very important hormones, including steroid hormone and another hormone called aldosterone, which helps to regulate salt and water balance in the body. So if a patient has to lose both adrenal glands because they have bilateral phaeochromocytomas, then those patients will become dependent on steroid replacement as a tablet and fludrocortisone, which replaces that aldosterone hormone I mentioned. And we know that this requirement or dependence on tablets to replace these hormones does have a huge impact on patients' quality of life, and does also affect or put them at a higher clinical risk because, for example, forgetting to take their steroid tablet or not being able to take their steroid tablet because they have vomiting or diarrhea can often mean that these patients require hospitalization to have it through their vein. So as RET gene mutations are less likely to cause malignant phaeochromocytoma, it's now become more accepted, if you like, that patients with RET gene mutations should be considered for partial adrenalectomies. That means that if we catch these phaeochromocytomas early enough, we can remove just the phaeochromocytoma and leave hopefully sufficient adrenal gland behind to still be able to make this steroid hormone and aldosterone hormone. And we know from quite a large meta-analysis, this is data from that meta-analysis, that in the correct center and in experienced hands, that a partial adrenalectomy can be successful in about 2/3 of patients. It's also important that we know from this data that it's very, very rare for patients who have a partial adrenalectomy to develop malignant recurrence or metastatic recurrence of their phaeochromocytoma. Recurrence of the phaeochromocytoma at the adrenal bed is more common in patients who have partial adrenalectomies rather than patients who have total adrenalectomies. But that will typically require just a repeat local operation, and was only seen in about 10% of patients who had a partial adrenalectomy. So the overall consensus now is that in the correct centers, and if these tumors are picked up early at a small size, we should be considering partial adrenalectomies, particularly in patients with MEN2. So the take-home messages: so medullary thyroid carcinoma is the highest tumor risk in patients with MEN2 and MEN3. The risk of phaeochromocytoma will vary, but it's somewhere between 10 and 50%, depending on the RET gene mutation. The highest risk from the phaeochromocytoma is related to the hormone excess and the potential cardiovascular complications, rather than the malignancy risk of a phaeochromocytoma, which is very low for patients with RET gene mutations. And what is very clear is that screening is essential to allow early detection and to reduce morbidity for patients. So I'm going to finish there, and I think we're planning to take questions at the very end. Thank you.
Thanks very much, Ruth.
Lovely. Thank you very much. So I'm Tom Kurzawinski. I'm a surgeon, and it's very good that Ruth gave us a very good background of what the multiple endocrine neoplasia syndromes are. And I'm going to focus specifically on the medullary thyroid cancer, but even more specifically about the medullary thyroid cancer in children. And the first part obviously was given by the Ruth. So the first part of my presentation will be about what we call a prophylactic thyroidectomy, and I will give a little explanation about that. And the second part of my presentation will be what do we do in the situation when children present with an advanced disease and we miss the opportunity to remove their thyroid before they develop medullary thyroid cancer. So just to remind everybody what happens in the thyroid of the children who are born with one of the RET mutations. So essentially, all children are born with normal thyroids, and these little golden spots here are calcitonin secreting cells called C cells. But then they develop a C cell hyperplasia, and that transition from a normal C cell to C cell hyperplasia depends on the type of the mutation. In a very high-risk mutations, it can happen very quickly within weeks or months. But in the other more typical mutations like 634, Ruth mentioned, it happens somewhere when the children are 3 or 4. And there are other mutations where this transition happens even more slowly. But then, almost inevitably, the C cell hyperplasia, which is itself not a cancer, but a pre-malignant condition, develops into medullary thyroid cancer within a thyroid, and then into advanced medullary thyroid cancer with the metastasis. And obviously, this is what we don't want, and this is what the surgery is aiming to prevent. So, if the child is born to a parent with the multiple endocrine neoplasia, they should be genetically tested. And if they found to have the RET mutation, and the risks of inheriting is 50%, and if the thyroid feels normal clinically and radiologically, and the calcitonin levels are reasonably within normal ranges or not very elevated, that child should undergo a total thyroidectomy in a high-risk mutation groups, and a total thyroidectomy and a lymphadenectomy in the highest one, which we called MEN2B. So I apologize, I will use a slightly old-fashioned nomenclature of 2A and 2B, and I will use some guidelines from 2009 rather than 2015, because I will be presenting the data which were collected in that part during the period when the mutations when the guidelines were used, written in 2009. So essentially, Ruth showed us that there are 3 groups. The old guidelines included 4 groups, but the difference is actually minimal. It is the highest risks, the D group, which can develop medullary thyroid cancer within the first few months, and then the high risk, which is 634 mutations, and the other risks. And as you can see, that the guidelines are fairly specific when they recommend testing, when they recommend first ultrasound, first calcitonin, and so on. And because there is such a phenomenal phenotype, genotype correlation in MEN2, we can sort of almost ask the question whether we can actually almost operate on these children by numbers and just do the mutational analysis, find out what mutation it is, and then decide about the treatment. And you will see from my presentation that to some extent that is true, but not always. So I will focus on this prophylactic thyroidectomy and then advanced cancer. And I will use data from the paper we published a few years ago. It was a quite big effort. We collected data from the whole of the UK, and we started 1995, because in 1993 red mutation analysis was introduced in the United Kingdom, and we carried on until 2017. We stopped. We have new data now, but they are not analyzed yet, so we are sticking to 79 children which were operated during this time in the United Kingdom. And you can see from the table there's a variety of the mutations and represent all 3 or 4 risk groups. So obviously we had a lot of data, we analyzed it, and the paper is very big, addressing many aspects of the MEN and prophylactic thyroidectomy. But today I decided just to focus on 2 things, and the timing of the genetic test. Because if you remember from the previous table that in the highest risk group, the children should have a genetic test as soon as the diagnosis becomes possible. And all the other groups should be tested somewhere between the age of 3 and 5. So if you look at the first, sorry, that's unfortunately jumped on me. Okay, so if you look at the first column here, then we can see that our children had genetic tests on average when they were about 4 years old. And that means that only 52% of our children actually had genetic test according to the recommendations by the ATA guidelines. So it's probably not too bad, given that this was a very beginning of introducing the red mutation and so on. And our results probably now a little bit better. But what that allow us to look a little bit further into what happens to the children who are actually tested when they are older. And we found out that a lot of these children have an abnormal calcitonin, about 76% of them. And 55% of the children who had a genetic test too late, they already have medullary thyroid cancer. So I think that our data shows that it's very important that the children are tested early. We measured the time between the positive test and surgery, and it seems that once the genetic diagnosis is established, majority of the children will have an operation fairly quickly. So the genetic testing is an important pivotal moment in how we treat these children. It's probably not surprising that if we look at the timing of surgery, which obviously depends on the timing of the genetic test, 54% of the children had it done within what the guidelines recommend. And again, it seems that the delay in operating was also important, because 78% of these children had abnormal high calcitonin levels, and 56% of these children had medullary thyroid cancer. Admittedly, it was not an advanced medullary thyroid cancer, but definitely medullary thyroid cancer detectable within the thyroid itself. So we have performed univariate and multivariate analysis of various risk factors, and I don't particularly want to analyze it in great detail, but I would like to, the takeaway message is that between 1997 and 2017, the children in the UK had their red testing and operations too late. And as a result, 3/4 of the children had elevated calcitonin. And about a third of the children developed medullary thyroid cancer at the time of surgery. So it seems that the thrust of our paper is that we're actually recommending earlier diagnosis and earlier surgery. But the question is, well, if you operate on a very small children, are you going to get more complications? Now, that was also an interesting finding, that we did not find any correlation between the age of the children and the complications, but we have found the correlation between type of surgery and complications. Now, we had very little complications such as nerve injuries. In fact, there were only 2 or 3 neuropraxias. There were no bleeding, no return to theaters. The only significant complication was hypocalcemia. But if you look at the incidence of the hypocalcemia in children who had only total thyroidectomy compared to children who had total thyroidectomy and lymphadenectomy, then you will see that this lymphadenectomy is an important risk factor in postoperative hypocalcemia. And obviously, if you operate on the children earlier, then you assume that they don't have medullary thyroid cancer and you can do only thyroidectomy. But if you operate late, you might have to include lymphadenectomy, and at least in the UK, and I'm sure that that would be reproducible around the world, the risks of postoperative hypercalcemia, both short-term and long-term, is higher. So this was the first part of the presentation, which really focused on timing and surgery, and the overall message is that we recommend to do the genetic testing as soon as possible, then follow the calcitonin, and the moment the calcitonin moves, we operate. Now, what to do in the situations when the children present with an advanced disease? And that usually happens when either this is a completely new mutation in a family, so there's no family history whatsoever, and that applies mainly to MEN2B, which is 918 mutation. And there are also some cases when it is a child who is an index case. The first case in the family diagnosed with a condition, then everybody gets tested, and then the genetic line is established. Now, this advanced disease usually affects children with MEN2B. And we know, as Ruth explained in her presentation, that they develop certain features which can trigger the suspicion that this is a diagnosis. Unfortunately, these children are not born with all of these clinical findings, and they develop it as they get older. So they might be born and they might look entirely normal, and they might not have neurofibromas and so on, and they will develop it later on, but it will be too late. And these children present usually with an advanced medullary thyroid cancer. Then they have the red mutation, which is found positive. And obviously, these children cannot have prophylactic thyroidectomies. They have quite advanced, big, long, and difficult operation, which aimed at removing the thyroid, performed lymphadenectomy, and resection of the organs, which sometimes structures, anatomical structures, which are involved in cancer. So this table is a little bit big, but if you just sort of looked at it column by column, this is 6 children who presented with advanced medullary thyroid cancer. And as you can see, they were quite old. The youngest child was 3 and the oldest was 12. And 4 of these children have 918 mutations, so they actually should have been operated within the first 6 months of their life. 2 other children unexpectedly had a different type mutations, which normally is associated with a relatively benign cause. And they developed complication, medullary thyroid cancer later, but in these 2 children, they presented with advanced cancer. The moment the diagnosis was made, obviously the operation was performed very quickly, but you can see it from the levels of calcitonin that it was a very advanced disease, and some of the calcitonins are spectacularly high, almost 50,000. All of these children had radiologically detected disease in the neck, which is unusual in early stages. And you can see from the lists of the sort of types of surgeries they had that they were very big operations, not just thyroidectomies. What happened to these children is that unfortunately, none of these children were actually cured by an operation. And until recently, we had a big problem as to what to do with these children. But fortunately, now we live in an era when we have the RET kinase inhibitors. So this is what these RET receptors look like. And when they open, like in this diagram here, there's no signaling of the tyrosine kinase. The ligands joined, then the unit closes and signaling starts. And that is a normal situation. But at the bottom of the picture, you can see various types of the mutations when the signaling actually happened without necessarily the presence of the ligand. And this is the problem in MEN2. And for some time, we had tyrosine kinase inhibitors, which can inhibit various types of tyrosine kinase. And because it inhibits so many, it inhibits it at so many different levels, there are very frequent side effects. But again, more recently, the pharmacological industry, pharmaceutical industry has developed a specific RET kinase inhibitors, which just inhibit RET kinase, which is new, and these drugs are much more specific. And in fact, all 6 children were treated with these new medications. So the first half of the table, the one on the left-hand side, just shows the situation before the operation. You can again see that after first surgery, calcitonin started rising to very, very high levels, and the children were just clinically not very well. And this is actually what happened to calcitonin levels once we started treating them with selpercatinib. And this is probably even a better, more graphic representation. This is the first child. The first arrow is an operation. We achieved some reduction in the calcitonin. The second yellow arrow, that's the child which was treated with external beam radiotherapy. We would not recommend treating medullary thyroid cancer with external beam radiotherapy. And the red arrow is introduction of selpercatinib, and you see what happens. The second child next to it is a first operation, second operation, which actually didn't achieve very much. And there was a significant reduction in calcitonin and CEA levels. And then you can see child 3 and child 4, all of them had very good responses. Child 5, the responses were a little bit mixed, and we are still observing that child. All the children still are on medications, and child 6 responded beautifully to the treatment, especially this is a child with a distal metastasis. So we were very pleased that the selpercatinib has shown an excellent therapeutic efficacy in children with MEN2. And what is very important, that in comparison with the previous drugs, we had almost no or very, very low grade toxicity. So we started this treatment 3 years ago. So the child who was started on it first, they've been on this treatment now for 3 years, and they're doing well. So that's probably I focused very specifically only on 2 aspects of medullary thyroid cancer in MEN, and I gave you the examples of what can be achieved by performing early prophylactic surgery, and that we now have very effective treatment for the children who missed the opportunity to have a prophylactic surgery, have an advanced disease and required a combination of surgery and chemotherapy. inevitably we have to address the issue as to where this patient should be treated, because MEN2 is an extremely rare disease. And if we look at our data over 22 years, that on average about 5 to 6 operations are performed in the United Kingdom each year, and most of the surgeons perform only 1 or 2 operations in their lifetime. So obviously that is not ideal. And we always talk about centralization of surgery, but I actually think that it's also important to talk about the centralization of care, because it's not just the surgical expertise, but also expertise of people like Ruth, which is also extremely important. So that is the end of my presentation. Just in a summary, I gave you a little bit of an insight into genotype-phenotype correlation in MEN2. I showed you what happens if we don't observe the recommendations by the guidelines. And we didn't talk much about the calcitonin, but happy to answer questions, because in many of our children, after what we would call a successful surgery, the calcitonin is still measurable, and we don't know exactly what it means. And I think that our paper proposes quite strongly, with relatively good evidence, that the children should be tested and operated early. And there are some new treatment options, and there will be more new treatment options in the future. Thank you very much.
That's great. Thank you very much, Tom. Now, we said we'd have questions at the end. So if anyone does have any questions, you want to pop them in the Q&A, and we will go through them. I mean, currently there's only one question in there, which I think Ruth is more up your street, genetics.
Well, I think Tom kind of answered that in his talk, but yeah, so I looked at this, what a de novo mutation basically means is it's a mutation that isn't detectable in the mom or dad of that patient, and it's likely a mutation that arose in the fertilized egg and sperm. So what happens in that particular case is, as Tom mentioned in his talk, is typically that patient will often present quite late, usually with medullary thyroid cancer. But for that patient's offspring, they would have this, depending on what the RET gene mutation is, they would have the same risk as any other patient with hereditary RET gene mutations. So what we'll see in that individual patient, for example, is that their mom and dad won't have the gene, mom and dad siblings won't have the gene, that patient's siblings won't have the gene, that patient will have the gene, and that patient's children could have the gene. They will have a 50% risk of inheriting the gene. So, and that patient will need to be screened for the other tumor phenotypes according to their RET gene mutation. So they will have the same risk as anybody else with that similar RET gene mutation, as will their children. So I hope that makes sense.
My 17-year-old has advanced MTC and MEN2B. What age should they start the RET inhibitors?
That is a very good question, but also quite difficult to answer, because MEN2B is almost, well, all of our patients with MEN2B have 918 mutation. Also, there are other 883s and so on, but I never had a patient with this rarer mutations. Our children, the 6 children who have advanced medullary cancer, were started on selpercatinib because they have a recurrent or disease which was not cured by surgery, and they were unwell. And they clinically, biochemically, and radiologically all improved, and they are now somewhere between 2 to 3 years on the treatment, and they're doing very well. So it very much depends how unwell the child is, and what are the biochemical and radiological evidence of disease, how advanced it is, because I stressed in my presentation that there is a very good correlation between genotype and a phenotype, but this is not always the case. I have children with 918 who are like that child you just asked about in the 16th and 17th, and they have quite highish calcitonin, and we know that there is a thyroid cancer somewhere there, but they are not unwell enough to have treatment. So I think that the answer to your question is it all depends on clinical presentation, levels of calcitonin, and how advanced is the disease radiologically.
Great. Hope that answers your question, Jenny. Yeah, I think because of the whole move, isn't there, towards personalized medicine, and I think that falls perfectly within that, isn't it? There's always an exception. People are always slightly different, so it's very much on an individualized basis.
So what we don't know is to precisely when to start and for how long to carry on. But I think that we are now abandoning the concept of chemotherapy for cancer only in the sort of terminal stages of the disease. That was definitely the case for the last 30, 40 years, but the chemotherapies were very toxic, they're not very effective, and one sort of kept it in reserve. Now, drugs like selpercatinib are extremely well tolerated. And as long as that drug is effective, it essentially puts everything on hold. It stops signaling down this red receptor. And it's not a cure, but it's a stable situation.
Tom, would you say as well, it's fair to say I know that thankfully some of the drugs that are available now are very, very well tolerated, but some patients will have some side effects. And so again, deciding when to start, particularly in that time period of 13 to 17 or 18, because that's such a crucial time in that child or adolescent's life as well, with school and friends and social networks, etc. But sometimes it's kind of a risk benefit weighing up. If the patient is asymptomatic and radiologically the disease isn't progressing very, very much, then it might be better for that individual child or adolescent to continue on with life for another few years until they need the drug more, rather than battle on with side effects from that drug at a crucial point in their life.
I can't agree more. I entirely agree. We shouldn't just put every single person on that medication. There has to be a background and a clinical decision. And obviously our biggest worry is an escape. Because, we know from highly effective, very, very, very precise biologicals is that the escaping mechanism at some stage, these children and the child number 5 might be just showing that escape. When the other children 1 to 6, they're doing phenomenally. We have reduced the calcitonin from 50,000 to 600. The children are going through the puberty, and they really don't have that much of a side effects, and it's a tablet twice a day. So I'm not encouraging that everybody should be on that new medication, because our experience is relatively limited, especially in children, because neither of the trials are quoted include children. We got all this medication on a special request.
The problem is, I think most rare cancers we're never going to have trials in children. So,
but we're trying to keep an eye on all of these children in the UK. Yeah. So 5 of these children are our children from Gosh. 1 is from Marsden, and there is just another 7th child joining. So we're keeping this is part of this centralization agenda. That to get the information fast and good information, it has to be very centralized. I don't necessarily think that everybody with fear should go to Cambridge and anybody with thyroid problem should come to Great Ormond Street, but they can't go everywhere.
We have another question come in for you. Amanda would like to know, are doctors tending to go away from vandetanib, which is considered an older drug? How often is it used now in MEN2B?
So I never use, well, I'm a surgeon. presenting my surgical experience, but obviously, clearly my surgery can't cure everybody. So I'm just giving a little bit of a background, but we have a big team of oncologists who make these decisions. The Vandetan is one of those multi-kinase inhibitor. It inhibits not only red kinase, but other kinases, and it has got quite a lot of side effects. And I know of only one child from Nottingham, before selpercatinib was available, with a very advanced disease, who had that medication. And that child did quite well for the time being on this medication. And there is a paper from Bethesda, I think, quite old paper, published at least 10 years ago, when children with medullary thyroid cancer were treated with quite good short-term results with multi-kinase inhibitors. But in your question, there is a hint that the doctors are abandoning this, and for reason, because the new drugs are more effective, more specific, and better tolerated.
That's great. Thank you very much. We haven't had any other questions now, and we're pretty much at the end now, 3 minutes to go of the session. So I think it's probably a good time to wrap up, and I hope that the session's been useful for people. So thank you very much, Tom and Ruth, for joining us this evening and for sharing your expertise on MTC and MEN2 and MEN3. And again, thank you to ThyCa, Gary and the team for allowing us to do this session this year. It's really been an absolute honour. So thank you very much to everybody.
Thanks, Jo.